Thank you, Jeff and Rahul there, and on all the folks at VCU for setting this up. This is a wonderful opportunity for collaboration amongst all the programs nationwide. And I'm pleased today to talk about adrenal surgery. So by way of introduction, I am an endocrine surgeon, been at Penn State now for a little over 12 years. My practice essentially involves thyroid, parathyroid, and adrenal surgery, as well as some neuroendocrine pancreas. So I'm going to take probably about the next 50 or 55 minutes or so and talk to you about aspects of adrenal surgery. There's no way we're going to cover everything, and happy to take questions. I will try to pop in and take a look at the chat as we go along, or certainly at the end. So feel free to type any questions. I do want to leave some opportunity to address any questions or things that weren't clear. I often start with just this idea, because we are surgeons, and so when we see an adrenal mass, the question becomes in our mind that all adrenal tumors need to be surgically removed. This is false, and the reason is what I hope to explain over the next again 50 or 55 minutes is that there's more to and more subtlety to operating on adrenal lesions than just removing a mass. There's a lot of underlying endocrinology that goes into it, and a lot of decision making based upon radiologic criteria and other surrogates for the malignancy risk of any particular adrenal lesion. So it took me several years in residency, if not through fellowship, to actually successfully find the adrenal glands on every CT scan. So here is an example of what normal adrenal glands look like and where they are anatomically located. So on the screen left is a picture of the right adrenal, and it is this lambda-shaped, thin endocrine gland that sits essentially hanging off the posterior or posterolateral side of the inferior vena cava, which is here. So this is the right adrenal gland, and you can see it nicely outlined by suprarenal or retrohepatic and retroperitoneal fat there. On the left side, the adrenal, in this particular image, it has slightly thicker limbs than the one that we saw on the right, but also has the same Y or lambda shape, and it sits posterior to the distal body or tail of the pancreas, medial or superior medial to the upper pole of the left kidney, again surrounded by retroperitoneal fat, and it is essentially just next to the aorta and the diaphragm here. So that sort of helps position them anatomically. Now, breaking them down a little bit more histologically, we think about the adrenal gland as essentially two glands in one. There is the outer cortical layer of the adrenal gland, and then the inner medullary layer. To start from the inside out, the medulla, which is a neuroendocrine derived tissue, gives rise to epinephrine and norepinephrine, or adrenaline and noradrenaline, and it is the outside of the adrenal gland, the cortex, that gives rise to the more traditional steroid hormones. You've got three layers. The outside has the glomerulosa, the fasciculata, and the reticularis. That's going from the outside to the inside. So you can remember that with a acronym of GFR, just like glomerular filtration rate. So the GFR, the outer layer, the glomerulosa, it makes your mineralocorticoid, your aldosterone. And then the fasciculata makes your cortisol. And then the innermost layer, the reticularis, makes your androgens, mostly dihydroepiandrosterone, specifically in the sulfated form is the most measurable one. The control of those layers is largely by ACTH for the inner two layers, the cortisol and the androgen. The exterior layer, the glomerulosa, is not ACTH controlled, but rather is responsive to potassium levels as well as angiotensin II as part of the renin-angiotensin system. Most of you are probably familiar with the general effects of the adrenal-cortical hormones. The mineralocorticoids really controls the extracellular fluid volume, and it does so largely through manipulation of both aquaporins, water channels in the distal convoluted tubules, as well as the regulation of sodium and potassium. And we can remember that when you have excess of mineralocorticoids or excess of aldosterone, you tend to be chronically low in your potassium level and relatively high in your sodium level. And it's largely the action then of aldosterone to lead to absorption of sodium and for electron neutrality within the kidney to lose potassium. Glucocorticoids, cortisol, really have a huge myriad of functions. They control a lot of components of metabolism, specifically carbohydrate and protein and even nucleic acid metabolism. We often can think about the actions of cortisol, especially when it is in excess, by increasing blood glucose, protein breakdown, as well as fatty acid mobilization. Certainly, we take advantage of the anti-inflammatory effects of cortisol in the pharmacologic dosings that we will often use. There is also a significant mood impact and behavior and emotional impact of levels of cortisol, and that has actually been quite well studied in the mood disorders such as major depression or bipolar disorder. Androgens, as you might suspect, regulate male secondary sexual characteristics. And it's just interesting to note that the androgens are actually controlled by ACTH and not gonadotropins the way testicular androgens are. The adrenal medulla that I mentioned actually derives from a separate embryologic tissue than the adrenal cortex and is actually enveloped by the adrenal cortex during organogenesis. The adrenal medulla comes from neuroendocrine tissues and works in essentially a paracrine fashion or a symbiotic fashion with the adrenal cortex. Specifically, this is the catecholamine biosynthetic pathway. The final step here from norepinephrine to epinephrine is catalyzed by an enzyme called phenyl N-methyltransferase. That enzyme itself is regulated by, and in fact is sort of as a cofactor from, it uses cortisol. So it relies on the local high concentration from the adrenal cortex to get to epinephrine. The clinical correlate of that is, for example, in a neoplasm of the adrenal medulla, so-called pheochromocytomas, you can get excess norepinephrine and epinephrine. When you have a neuroendocrine tumor that is making catecholamines outside of the adrenal, we call those paragangliomas, they are unable to convert the norepinephrine to epinephrine because of the relatively low local concentrations of cortisol. So if you have a paraganglioma, you will see elevated norepinephrine, but not epinephrine. Whereas if you have a pheochromocytoma, an adrenal medullary tumor proper, you can see elevations in both. So you can use your biochemical parameters to give you a clue as to where you should go looking for a catecholamine secreting tumor. So why did I tell you all of this? This is a lecture to surgery residents. It is not a lecture to endocrinology fellows, but I tell you this because in the evaluation of an adrenal lesion, you have to think about both structure and function. Both of those have branch points that will lead to the decision for surgical removal. And again, as we start off the very beginning, we don't just remove every adrenal lesion. We have to evaluate it for its structural issues, such as risk for cancer versus a benign lesion, and its functional issues, risk for or proven hormonal oversecretion versus just a non-functional lesion. And so in thinking about the functional disorders of the adrenal gland, you can sort of break it down. The first 3 bullet points here show you the categorization of hormone excess production, both in the first 3 here are from the cortex, and then this one, the 4th bullet point, is from the medulla. So endocrinology has a long and storied history, and you see a lot of eponyms. Excess aldosterone in a primary fashion has the term Kahn's syndrome, after Jerome Kahn, who was actually a urologist working in Michigan for the description of this syndrome. Hypercortisolism is elevated cortisol either due to a primary source within the adrenal or being driven by a source of ACTH from within the adrenal, within the pituitary, or somewhere else in the ectopic phase. And that goes by Cushing's disease or Cushing's syndrome. And I tend to actually try to stay away from that terminology because of the risk of being confusing. Are you talking about an ACTH source or a ACTH independent source of cortisol? The other functional disorders are when you have lack of adrenal cortical function. We don't really describe too much lack of adrenal medullary function, but lack of adrenal cortical function if you have an autoimmune condition, for example, and have a destruction of the adrenal cortex that results in primary adrenal insufficiency. In endocrinology parlance, when you have loss of the controlling hormones, we call that a secondary process. So secondary adrenal insufficiency is when your adrenal cortex itself is intact, but you have an absence of ACTH control of the adrenal cortex, such as after pituitary surgery or neurotrauma. This is a long list of all of the structural lesions that we see, and it includes both functional benign lesions, which is the vast majority of what we're going to see in the adrenal, as well as non-functional malignant lesions. And then there are all of the variants of benign and malignant functional tumors. We are not going to go through every one of these in detail. Don't worry about that. I'll show you pictures of some of these, especially things like a myelolipoma have a fairly pathognomonic radiologic image. We have some of the adrenal medullary neoplasms, both in the adult pheochromocytoma, as well as in the child, the neuroblastoma. And then the adrenal is also the site for metastases, and we'll go through that. And then finally, you have a number of cystic lesions of the adrenal, which are largely benign. And then this is not a neoplastic lesion, but sometimes can mimic it. You can certainly see hematomas within the adrenal after trauma, and those need to be differentiated from primary neoplastic sources, or was there an underlying neoplasm that bled during the trauma for a fall or a blunt trauma of some other variety that needs to be followed and evaluated. Going very briefly into adrenal insufficiency, which is not going to be something that we surgically manage. We sometimes surgically cause it by taking out the adrenals, or both adrenals specifically. But just to give you a brief peek into primary adrenal insufficiency, there can be genetically inherited forms or autoimmune forms. We certainly see infectious forms. A classic, though very uncommon at this point, is tuberculosis of the adrenal can lead to primary adrenal failure. If you have large enough volume of metastatic disease to an adrenal, you can lose function. It pretty much requires complete replacement of both adrenals, however, to get that, because as is the case in much of endocrine tissue, you have a significant redundancy of function. And so to lose adrenal function from metastatic disease, you essentially have to have two large volume metastases, one on each side. You can get adrenal hemorrhage, I mentioned, from trauma, but also a classic case of infectious causes of adrenal hemorrhage goes by the name Waterhouse-Friderichsen syndrome, and we do see that occasionally in the pediatric population. Again, I mentioned secondary causes of endocrine failure is due to the loss of the controlling hormone, and that's just when you have structural hypothalamic or pituitary disease, or if you're taking or have recently taken some higher dose glucocorticoid therapy that can suppress endogenous ACTH as well as CRH, and then lead to a secondary adrenal insufficiency. What can precipitate acute adrenal insufficiency? I mentioned infection, but things that we do as surgeons all the time can occasionally do it, surgery or trauma or certain drugs. The one that I really want to highlight briefly, because it does come up both in real clinical care as well as on the AB site, is etomidate, which is an anesthetic induction agent. It is a known suppressor of one of the enzymes within the steroid hormone biosynthetic pathway, the 11-beta hydroxylase, and even a single dose of etomidate can lead to adrenal insufficiency and adrenal suppression for up to 72 hours. So this is something that if you have a patient that you're suspicious of adrenal insufficiency due to refractory hypotension or altered electrolytes, such as hyperkalemia and hyponatremia, you do want to look back at the anesthetic record and see if etomidate was administered. So moving on a little bit, just to show some pictures to break up some of the text slides, I want to show you some images of adrenal structural disease, and then we'll talk a little bit about some of the specific pathologies and then move into some considerations of adrenal surgery. So this is a classic picture of a left-sided adrenocortical adenoma. So it's marked here with a radiologic circle, just for orientation, pancreas here, spleen here, aorta here, diaphragm here. And so this lesion is an adrenal lesion, and this is ultimately an adrenocortical adenoma. Without much more information on the scan, you couldn't tell that, but you can see it has very well-defined margins. It is homogeneous, and were you to do some measurements, it would have low Hounsfield units. Compare that, however, to an adrenocortical carcinoma, also on the left side. You see this very large heterogeneous mass that has brighter areas, has darker areas, does not seem to be having good margination with either the diaphragm posteriorly or potentially the pancreas anteriorly, and this is ultimately an adrenocortical carcinoma. I mentioned in the list of structural diseases something called myelolipoma, and this is a benign lesion. These are very well identified radiologically and have sort of pathognomonic signs, and specifically if you see what we term macroscopic fat, so if it looks like the retroperitoneal fat is just inside this lesion, and you're seeing large areas of fat, of really gross looking fat inside the lesion, that is pathognomonic for a myelolipoma. These do have bone marrow elements as well as lipomatous elements. These are benign lesions. We don't always know why they form. Many times they're picked up just incidentally. However, they can also be seen actually bilaterally and quite large in patients who have variant forms of congenital adrenal hyperplasia. And we usually don't need to bother removing these unless they become symptomatic from a mass effect standpoint. These can get up to 20, 21, 22 centimeters large, and those usually do have some mass effect. Pheochromocytomas are the usually benign but neoplastic tissue of the adrenal medulla. Don't always look so different than adrenal cortical lesions. Upwards of 50% or so on T2 weighted MRIs will show a very bright lesion. And that is can be pathognomonic both for either a pheo or a cystic adrenal lesion. Both can show up right on T2. It used to be sort of said that that is classic, although it's probably closer to maybe 50% of the lesions rather than certainly 100% of the lesions. Bilateral large adrenal masses, while you can see those from primary adrenal lesions in the setting or in the right setting, especially with a known other malignancy, you have to think about metastases. So the adrenal is a site of metastatic disease. And speaking of that, so here is the list of the common types of malignancies that do metastasize to the adrenal. You will classically see breast cancer as well as non-small cell lung cancer. Melanoma can metastasize almost anywhere. I've absolutely seen it go to the adrenal, even in the relatively oligometastatic state. Melanoma metastatic to the adrenal is seen. I've seen melanoma actually metastatic to a pheo. That was fairly uncommon, but you can see that as well. Renal cancer, colon cancer, prostate, esophageal, and lymphomas are all also seen in the adrenal. There are good data, especially for breast cancer and for non-small cell lung cancer, as well as melanoma, that resection of an isolated metastasis, even though it means stage 4 disease, offers the patient better disease-specific outcomes than chemotherapy alone. That's a little bit of a broad statement, but there's good data to support that. So adrenal incidentalomas, or an incidentally identified adrenal lesion, is certainly something that we will deal with, frankly, most commonly. And by definition, it means that you have found this lesion when you are looking for something else. So you're doing a scan for abdominal pain or a kidney stone or any number of causes, and you find an adrenal lesion. They are actually relatively common. You'll see quoted numbers anywhere from 2 to 7%. We see that on imaging, as well as when autopsy studies have been, or series have been done. The questions to ask in my mind is, does it need to come out? And how do I make that determination? I break that into 2 questions. Is it functioning? And is it malignant or worrisome for malignancy? The details of the endocrine workup or the endocrine hormone workup sort of depends upon the presentation. And I say sort of because I will say that in my practice, I generally do a fairly thorough serologic screening of the adrenal hormone levels, regardless of symptoms, because each of these, whether it's cortisol producing or aldosterone producing or even a pheochromocytoma, can have asymptomatic lesions identified. So I generally do a fairly thorough biochemical evaluation, although you could make arguments for targeting it based upon the patient's specific history. I will say, and get into this again, that the exception to that is pheochromocytoma. Regardless of any signs or symptoms, you should work up every adrenal lesion for a pheochromocytoma, given the potential significant downsides of missing that diagnosis. And then to get to the malignancy risk, you need to look at the imaging characteristics, size, Hounsfield units if it's a CT scan, as well as any rate of change. So I will stress this again, that you should think of a pheochromocytoma with every adrenal mass, without exception. I assume everybody has a pheochromocytoma until proven otherwise, and that's not obviously going to pan out. But I think if you go into an evaluation of an adrenal lesion with that mindset, you're not going to miss something. You are very, very rarely ever going to biopsy an adrenal. However, if you are going to intervene on an adrenal, whether it's a biopsy, again, there are very few circumstances that you want to do that, or certainly if you're going to operate on them, you should have biochemical proof that this is not a catecholamine secreting lesion. An adrenal biopsy of a pheo could lead to pheochromocytoma crisis or death. Adrenal biopsy is not one that you really want to do lightly or frankly almost ever. In part, it is because your ability to delineate adrenal benign cortical lesions from adrenal malignant cortical lesions is quite difficult, just based on the pathology. And if you are looking for a cancer, and it is a adrenal cancer, you will have spread it. This is one of the this is one of the cancers that will spread through needle tracts, and you convert something that is potentially curable into a disseminated disease by putting a biopsy needle through the capsule of the tumor. The only real time that I think you should biopsy an adrenal is if it will significantly alter the oncologic management of a known additional primary cancer. And this is really the most straightforward of the metastatic lesions to biopsy. And you're not going to be then operating on it for essentially cytoreduction of any disseminated cancer. When you have an adrenal incidentaloma, the vast majority of them, and even these numbers I will fully admit are a little bit on the older side at this point, the vast majority are going to be adrenal adenomas or benign adrenal lesions that are non-functional. There are some series that will say in these incidentalomas, and this is a all-comers pie chart, not looking at specific size, that you could have adrenal cancer up to 12% of adrenal incidentalomas, and that is a little bit on the high side. So when you are thinking about the adrenal lesions that need to come out, we will often think about surgical removal for the adrenal lesions that make excess hormone from a unilateral source. So I evaluate all of these folks with assessment of each of the hormone axes. So for the glomerulosa of the cortex, I look at aldosterone level, and it's not just the aldosterone level, you have to look at the ratio of the aldosterone to renin. And so again, aldosterone or renin activity level, as well as the potassium. For the fasciculata, you want to look at total levels of cortisol. So we usually do that with a 24-hour urine-free cortisol. You can do salivary cortisols both morning and night for several iterations, and you're looking for lack of diurnal variation. And then you may need to do some further investigations with dexamethasone suppression testing test, as well as ACTH levels, and I will go through that in a little bit. As far as the reticularis, the androgen-producing layer, you want to check a dihydroepiandrostenedione sulfate. That's the most specific form and is measurable. And then again, there are a number of different ways to test for pheochromocytoma. I personally use plasma fractionated metanephrines and normetanephrines versus any other plasma or blood catecholamine screen, and versus even urine catecholamine or VMA or metanephrine screens. To go a little bit into the diagnosis of Conn's syndrome or a primary hyperaldosteronism is when you have an adrenal tumor or hyperplasia bilaterally that makes excess aldosterone. As I mentioned before, aldosterone leads to sodium absorption and concurrent potassium excretion by the kidney. Water will follow the sodium and you increase your extracellular fluid volume. With that increased volume, you will have increased flow through the afferent arterioles of the glomerulosa, and the juxtaglomerular cells will decrease its renin production. So ultimately, if you have a autonomous or neoplastic source of aldosterone, which is what primary hyperaldosteronism is, you will have excess aldosterone and decreased renin. And this is why when we're evaluating this, we are looking at the ratio of aldosterone to renin. If you have unilateral disease, if you have an excess aldosterone source from one adrenal, adrenalectomy will definitely cure your hypokalemia. And depending on the longevity and the number of antihypertensive agents, you will have a very good chance of curing or certainly impacting the hypertension. Upwards of 2/3, though, of adrenal aldosterone overproduction is from bilateral disease. In this setting, we do not really offer adrenalectomy because it will seldom correct the hypertension by doing a unilateral adrenalectomy. And for this disease process, because there are pharmacologic options, we do not want to take out both adrenals. So we generally want to operate only on unilateral disease. So if you have someone with an adrenal nodule and you have biochemical evidence of excess aldosterone and suppressed renin, how do you know for sure that your visualized structural lesion correlates to the systemic biochemical finding? And that's where we put into play something called adrenal venous sampling. And that's a method done usually by our interventional radiology colleagues to help distinguish unilateral or adenomatous versus bilateral or hyperplastic changes. And what is essentially done is under radiologic or fluoroscopic guidance, they are able to cannulate and draw specific aldosterone as well as cortisol levels from the right adrenal vein, from the left adrenal vein, and then comparing it to the systemic or the IVC levels. And there are a number of ratios. I think that the most important ratio to remember is right here. When you check each side's aldosterone and cortisol, you take a ratio of aldosterone to cortisol, and then you look at the dominant side relative to the non-dominant side, the side with the lesion relative to the side without the lesion. And if you have a ratio of at least 4, that suggests a true unilateral source of aldosterone. There are a number of built-in ratios that are not important to memorize right now that tell you if your catheter was in the right place, that confirms contralateral suppression. But if you're going to remember one number, you want a ratio of lesional side aldosterone to cortisol to non-lesional side aldosterone to cortisol of greater than 4, supports a diagnosis of unilateral adrenal aldosterone overproduction from an adenoma, otherwise known as Conn's syndrome. We can treat hyperaldosteronism pharmacologically, which is one of the reasons we don't operate and do bilateral adrenalectomies for this. So there are specific aldosterone antagonists, both spironolactone and eplerenone. Oftentimes you'll have to go through a spironolactone before you get to a eplerenone because of cost issues. If neither of those are working, you can use sodium channel blockers, specifically amiloride and triamterene. And then there are some aldosterone synthase inhibitors in clinical trials. One of the more confusing evaluations is for hypercortisolism. So how do you evaluate hypercortisolism? So you have a patient that you are suspicious of hypercortisolism, or you have a patient who has an adrenal incidentaloma and you want to evaluate hypercortisolism. The easiest way to start is to measure a 24-hour urine-free cortisol. With that, you will say this person has elevated cortisol or not. If it is elevated, then you proceed on an evaluation, and now your goal is to confirm that that elevation is truly due to some derangement of their endogenous hypothalamic pituitary adrenal axis. And the way we do that is a low-dose dexamethasone suppression test. A low-dose dexamethasone suppression test takes advantage of the fact that the hypothalamic CRH and the pituitary ACTH will be suppressed with cortisol and then subsequently lead to lack of stimulation of the adrenal cortex. When you're doing a low-dose dexamethasone suppression test, you want to see, is there normal suppression within the axis? Can we mimic that, suggesting that there is an intact endogenous hypothalamic pituitary adrenal axis? So we give a low dose of dexamethasone and then check the cortisol the next morning. If it is suppressed, and the magic number to remember is 1.8, if it is suppressed, that suggests an intact hypothalamic pituitary adrenal axis that is not supportive of excess cortisol from that adrenal lesion. If it is not suppressed, that tells us that there is some autonomy in the hypothalamic pituitary adrenal axis. So then what do? Then we want to see, is this ACTH dependent or not? So you check an ACTH level. If you have a suppressed ACTH, that means that your cortisol production is independent of ACTH. There is one and only one place that you can get that from. That's the adrenals. I guess there's really two places, the left adrenal or the right adrenal. You cannot have ectopic cortisol production. To get cortisol, it requires many biochemical, biosynthetic steps. And even if you have a malignant tumor of something, you are not going to recapitulate that entire biosynthetic pathway somewhere else. So the only source of cortisol is the adrenal. So if you are making cortisol without control of ACTH, it's coming from either the left adrenal or the right adrenal. If your ACTH is present at a normal or high level, now you have ACTH-dependent hypercortisolism. This then requires delineation of where is that ACTH coming from. This is when we do the high-dose dexamethasone suppression test. A high-dose dexamethasone suppression test does exactly what it sounds like. It gives a higher dose and attempts to suppress this ACTH production. If the ACTH production is suppressed, then leading to cortisol suppression, that is coming from the pituitary. The pituitary, even in a neoplastic form that makes ACTH, still has the steroid hormone receptor and the biochemical machinery to shut down ACTH production. It just takes a higher dose of dexamethasone than the low dose did. If you have an ectopic source, even if it wanted to be suppressed, usually it's just a genetic change that has constitutively activated the ACTH synthesis. It doesn't have the intrinsic biochemical machinery to respond to steroids, so it doesn't matter how much dexamethasone you pour on that ectopic tumor, it can't shut it off. So if you have pituitary source of cortisol, pituitary source of ACTH, then you do a pituitary MRI to look for the tumor. And sometimes you need to do some more invasive sampling to figure out if it's the left side of the pituitary or the right side, if you can visualize a lesion. If your cortisol does not suppress with high dose dexamethasone, then you have to start imaging all over, knowing that some likely sources may be lung or pancreas for ectopic ACTH secreting cancers. To talk for a few minutes about adrenal imaging. So those prior slides were all, how do we assess the function of an adrenal lesion? And you'll notice I didn't go into detail about pheochromocytomas because that adds a whole nother layer, but essentially checking, as I mentioned that I do, the plasma fractionated metanephrines or norepinephrines. All of those tell us if this is functional and specifically unilateral, which would benefit from adrenalectomy. Now we want to switch to thinking about how do we just image these in general? And we often use a CT scan, and you'll hear people talking about an adrenal protocol. And what that is a way of seeing how much adiposity or fat this lesion has, because benign adrenal cortical lesions have a lot of intracellular fat because it's necessary for the steroid hormone synthesis, so they tend to look very dark. So on non-contrast imaging of adrenal lesions, if you have Hounsfield units less than 10, that is consistent with a benign cortical lesion. However, sometimes it doesn't meet that, and what we do is we give contrast at about and image it like at about 2 minutes after the contrast, and then at about 10 or 15 minutes. And we want to see what is the rate of washout of that contrast. adrenal lesions that are benign do not have a lot of neovascularization. They have a lot of fat, and they will not hold on to the contrast. So you will see a washout rate when doing some ratios of your Hounsfield units of at least 50 or 60%. Those suggest benign lesions. There are other imaging modalities that we can try to use to assess for benign versus malignant. Things like the signal intensity on an MRI. I mentioned the T2 hyperintensity, but MRI is in general a little harder to interpret. It takes longer to image, and it is more costly. We use an adrenal lesion size as a cutoff. So generally anything over 4 centimeters, we are more worried about malignancy. It is very uncommon to identify adrenocortical lesions at a small size. So if a lesion is less than 4 centimeters, we are much less worried about it being malignant. And as the size goes up, especially to over 6 centimeters, you start to see a significant rise in the risk of malignancy. So we do use size as a proxy for adrenalectomy, and 4 centimeters is the number to remember. This is a flow chart sort of summarizing what I previously described here about an incidentally identified adrenal mass, looking at its size and its Hounsfield units, and then also thinking about if it's functional or non-functional. So I'll leave that up for just a second. I do want to talk briefly about adrenocortical carcinoma. So this is a picture of a very aggressive looking 15.5 centimeter right-side adrenal cancer. It's depressing the location of the kidney. It's invading the liver. Somewhere in here used to be an inferior vena cava that's invaded. You can see it creeping up on and deforming the aorta even. So this just looks bad. Adrenocortical carcinoma is bad. It is a very lethal malignancy with very limited therapeutic options. Really the only chance for cure, especially in the early stage or small size, is complete surgical resection. They tend to not have symptoms. Even with a large lesion, you don't have a lot of mass effect symptoms. And so we typically don't identify them until they're larger size. Further, we sometimes identify earlier on the ones that make hormone, but they still are typically identified at a large size. And especially when they're small, without the right phases of imaging, it is difficult to figure out a benign adenoma from a malignant adrenocortical carcinoma. And really a small lesion, say those less than 5 centimeters, are really the only ones that have some good oncologic outcomes with resection. It is an uncommon malignancy. There's only about 600 cases of adrenocortical cancer per year in the United States. That gives you a rate of 0.6 to 0.7 per million. Most of them occur in the 5th decade of life, but you also will see some young children with adrenal cancer. It has a slight predilection for female sex, although not as much as we see in much other endocrine pathology, especially thyroid pathology, where it's almost 3 or 4 to 1 female to male. You can see adrenocortical carcinomas associated with some genetic syndromes, Lee-Fraumeni, which is a TP53 mutation, Beckwith-Wiedemann syndrome, and the FAP and HNPCC, which we know much more from colorectal carcinoma. You can see them at a slightly higher rate in MEN1. We think of MEN1 as parathyroid, pancreas, and pituitary. We do see an increased rate of adrenal lesions, most of which are benign, but some of which can be adrenal cancer. About 50% of adrenal cancers are hormone secreting, and about 50% are not hormone secreting. In the pediatric population, most of the hormone secreting ones are actually virilizing. They're making androgens. In the adult population, you tend to see cortisol production as the predominant hormone of adrenocortical carcinoma. Sometimes you see mixed ones that are both cortisol and virilizing. The mean tumor size at diagnosis for adrenal cancer is about 12 centimeters, and the overall 5-year survival is pretty dismal at between 19 and 35%. About half of the time, adrenal cancer is identified at a metastatic state at stage 4, and we see metastases primarily to lung and liver, but you can see it also to bone and brain. Metastatic disease or stage 4 disease is usually considered unresectable. The exception being when this is a cortisol-producing tumor, if abdominal operation or other metastasectomies can ultimately yield at least 90% tumor resection, then you might be able to offer that individual surgery for palliation, especially of their end-stage hypercortisolism. The classic criteria that are used to identify adrenal cancer is called the Weiss criteria. This dates back several decades at this point, and they're listed on this slide. And these can be quite difficult to assess, and that is one of the reasons that adrenal percutaneous biopsy will not yield the diagnostic information that you're hoping for, as well as I mentioned before, penetrating the capsule of an adrenal cancer essentially guarantees local spread of that tumor. Just some of the TNM definitions. I mentioned 5 centimeters is the, if you're going to have a chance of surgical cure, because that's a T1 lesion, so the smaller the lesions, the better the chance. And this is the type of cancer that the smaller the lesion, the bigger the operation. You want to make sure you get anything it's potentially touching, because really a surgical R0 resection is critical for any potential at surgical cure. Here's a list of 5-year survival by stage, and you can see that when you get to stage 4, the 5-year survival is essentially 0. I think I had said most of this already, but completeness of resection is a critical prognostic factor. So in the last 15 minutes or so, I do want to talk briefly about options for adrenalectomy. The classic way that adrenalectomies were done was either through a bilateral subcostal or a vertical midline incision. And that was largely done at the time when Charles Mayo was doing these at the Mayo Clinic initially here in the United States, saying, we know we have a patient with a catecholamine secreting tumor. We know it's in one of the adrenals, but we don't have the advanced imaging to really figure out which one it is. A vertical midline or a bilateral subcostal incision gives you access to both adrenal glands to look for the mass. Certainly today we have much more robust imaging methodologies. We still do an open anterior approach, especially in the worry for malignancy. There are posterior approaches, both in the open fashion, which is diagrammed here. We don't see this very much anymore. There's hockey stick incision, as well as what has really been transformative is the laparoscopic or endoscopic approaches. Both transabdominal and retroperitoneoscopic have really replaced any open approach for all benign lesions. Depending on the group of literature you look at from European societies versus the United States, even some of the smaller malignant lesions. You can do on the right a thoracoabdominal incision if you have a very large tumor and need to gain access to supradiaphragmatic control of the vena cava. You will see descriptions of laparoscopic versus robotic adrenalectomy, and that's there are really subtle differences there. And then the final one I want to mention is a partial adrenalectomy, which is really otherwise known as a cortical sparing adrenalectomy, and that's an attempt, especially when you have bilateral disease, to preserve endogenous cortisol functions so that the patient is not becoming dependent upon steroids. Laparoscopic or retroperitoneoscopic is really a safe and effective now for nearly all patients. It has, similar to other surgeries, much less bleeding and morbidity than open approach, or more rapid discharge from the hospital, return to work, less use of pain medications. There are numerous benefits to using minimally invasive surgery. My personal preference for open approach is when you have a large tumor, and that definition of large is variable, somewhere between 6 and 8 centimeters, and I push it to larger numbers even when for when you're dealing with a pheochromocytoma, due to the likelihood that even a large pheo is still benign. Certainly, if there is imaging evidence of malignancy, you want to do an open operation that could be contested. Again, I mentioned some of the European literature, especially for small size T1 and T2 tumors. They would consider a minimally invasive approach that is less popular here in the United States. Any intraoperative difficulty or unnamed and extra retroperitoneal vessels or adhesions or invasion would suggest on a laparoscopic exploration that this could be malignant and should mandate an open operation or conversion to an open operation. Everything about adrenal surgery has to do with saying, where is the vein? Yes, there are some arterial blood supply to the adrenal gland that is usually dealt with through some electrosurgical devices. Really much about the operation is identifying the vein and clipping it, stapling it, harmonic, whatever you want to use. And then the rest of the adrenalectomy is separating it from the surrounding retroperitoneal fat. So there is a tremendous amount about the surgery and how you do it is to say, where is the vein and how do you get there? So starting on the left, you generally will need to mobilize some of the splenic flexure. You will want to open the retroperitoneum and start by elevating the spleen and the tail of the pancreas from its retroperitoneal attachments. To open a book, essentially, with a front cover of the book being the spleen and tail of the pancreas, and the back cover of the book in the retroperitoneum being your left kidney. The pages of the book is your adrenal gland. And so as you start to do this, you, again, mobilize spleen and tail of pancreas towards the downside or the medial side. You identify and separate the adrenal from the kidney. And what you're looking for is the adrenal vein. And again, the adrenal vein on the left drains into the renal vein. So here's renal vein, and there's the left adrenal vein. This is a still image from a laparoscopic view. A for orientation is adrenal. PV is phrenic vein, so you can have sometimes the phrenic vein draining into the adrenal vein here. And so this is the adrenal vein draining into what's down here, the renal vein, with the kidney over here on the screen right, and the spleen and pancreas up here on screen left. So this is really the crux of the operation, is identifying the vein. On the right, you start by mobilizing the liver, the right triangular ligament will allow you to roll the right lobe of the liver up and off the retroperitoneum, and then you have to incise the retroperitoneum to really help free the adrenal gland, which is just underneath the retroperitoneal layer below the liver. Once you elevate the liver with whatever retractor, you will see the adrenal gland. Just caudal to that will be the kidney, and then medial to that is the inferior vena cava. Shown here are a couple of adrenal arteries that are ligated that really you're going to just use some electrosurgical device to go through, but the crux of the operation is separating the adrenal from the central adrenal vein, which goes directly into the posterior side of the vena cava. It's a very short vein, it's a very fragile vein, and it's relatively wide. And any hole in the right adrenal vein is essentially a hole in the vena cava. So this is the anxiety-provoking step for the surgical team to make sure that you gain access and secure that vein. I have one of the two pictures here. This is, it's not the clearest, but if this is the liver here, here is your vena cava with the adrenal gland and tumor here. This is a cortical-based tumor. You can tell by this orangey color. And this is the short adrenal vein that you need to secure. I usually personally use 10mm clips. This is another view where you can see the vena cava a little clearer as it goes up here. The adrenal is here, and then here's a clipped adrenal vein. And I know this looks like it's relatively on the lateral side of the vena cava, but keep in mind that this is an operation, at least when I'm doing it in the picture shown here, in the decubitus position. That's a transabdominal approach, so this is actually off the essentially the posterior side or the bottom of the cava. And why that's so important is if you have any bleeding at this point, it can be difficult to control laparoscopically. Certainly for your boards, you would want to say that if you ran into bleeding, you'd want to convert to open for control of that and repair of that vena cava, because it would be quite difficult to do in a laparoscopic approach. So I will close there. Certainly in the last 5 minutes or so, happy to take any questions. And I thank you very much for your attention.